you for all these introductions. We will start our panel discussion. In the interest of time, we will not make introduction of the bios. I hope you are familiar with our speakers by now. And I will apologize also. I may call people by first name to move things fast. And I'm just declaring this ahead of the discussion. We will try to go through the three main discussion areas, which starting with the strategies of improving cancer care in limited resource areas. A few of our panelists have presentation. We're going to limit that to hopefully 5 minutes. And after they finish their responses to the areas of discussion that we will be having subsequently, we will open the floor for discussion. So you may want to note your questions, and that will be dealt with once we are done with the three main areas of discussion that we have for the panel. So again, it's good to welcome our panelists. The first question or the area of interest that we would like to explore is the strategies for delivering effective cancer care in regions with limited resources. And the focus would be on innovative and cost-effective approaches. So the question is, what are the low-hanging fruit and what innovative strategies would you focus on if you had the option to influence policy and strategies in countries? So the first speaker is going to be Mr. Sorek.
Thank you so much for inviting me for this very important conference. My name is Noam Sorek, and I'm working in IceCure Medical. And in IceCure Medical, we are, in general, freezing cancer in its tracks. We do it globally around the world, and hopefully from now, we're going to do it also in Africa. So IceCure Medical is an Israeli medical device company founded to advance treatment of tumors. I would like to present you a quick video that explains in 1 minute about cryoablation and what we are doing. Can you play, please?
Or to choose tumor treatment with minimal to no pain, free from long hospital stays, and with the option for local anesthesia or light sedation. The power to choose cryoablation. Uniquely utilizing liquid nitrogen, this fast, minimally invasive treatment is providing a new alternative for patients and physicians worldwide, freezing away benign and/or cancerous tumors, with promising interim results for small, low-risk breast cancer and 100% satisfaction with cosmetic results as the breast remains whole. It can be performed under local anesthesia or light sedation in less than an hour, with little to no pain or discomfort, minimal to no scarring, and rapid recovery. Now you can freeze your cancer, not your life. Cryoablation by IceCure. It's your choice.
So our mission is to create new choices in cancer care for physicians and patients with minimal invasive cryoablation procedures. And in general, we would like to create the awareness, mainly in Africa, for alternatives for surgery. Not everybody has to go through surgery, and there are alternatives. So our presence around the world, as you see, this is the blue colors, and what is coming into your mind, I think, in the first sight is that Africa has no presence. We have some activities in South Africa, but I hope to come here in a couple of years and to start seeing some blue also in Rwanda and, of course, in Africa. We have just 5 minutes, so I'm not going to go over it. I think the best is to show you another video to understand more about cryoablation. Would you please play it?
IceCure Medical's ProSense cryoablation system destroys tumors by freezing them. The minimally invasive procedure uses a needle-like cryoprobe to create an ice ball around the tumor using liquid nitrogen in a close-looped system. Cryoablation is performed in an office with local anesthesia in less than an hour, with rapid recovery, significantly lower cost, and great cosmetic results compared to surgery. The ProSense system can treat tumors in the breast, kidney, lung, liver, and be used for other treatments in interventional oncology. IceCure's ProSense, the next frontier in cancer treatment.
Okay, I'm not going to go over this. We don't have much time, maybe later on. But in general, the system is doing freeze, thaw, freeze. This is the best option for destroying the lesion. And this is the cryoprobe. You can see in the middle, the cooling zone center, minus 170 degrees, up to going to minus 20 degrees. The whole lethal area is the area where the lesion cannot live after this procedure. Let's keep going. We are using liquid nitrogen. If you see the green line going down, it achieved a rapid temperature decrease at the beginning of the freeze procedure, which is very important for the destroying mechanism of the lesion. And throughout the whole procedure, it's very stable, low freezing temperature, which is very important as well. Just quickly, the difference between cryoablation and thermal ablation, which are more popular here in Africa because it's a bit cheaper, but there are some main advantages. First of all, pain. There is minimal to no pain with cryoablation. When I'm playing football and I got injured, they are coming with this spray, freezing it, and the pain is gone. With thermal, it's very painful. Then it brings us to the fact that you do not need anesthesia. Just lidocaine, and the patient can go through the procedures. Visualization. You can see clearly the boundaries of the ice ball. And this is very important when you do it with ultrasound or a CT, because you know where you are and not to damage any essential organ or make sure that you are doing the right things. With a thermal, there is vapor and you cannot really see. Another important thing is the immune response. We know today that cryoablation stimulates the immune system, and it's getting better and better, and we can elaborate about it afterward, but we have some studies that prove it. This is just, you can see here on the left, the thermal ablation, where you do not really see where you are, compared to the very good visualization of the ice. How long I have? Okay. Challenge in breast cancer surgery. Breast is a huge thing here in Africa, and in terms of cost, I know each market has its own characteristic, but it's supposed to be cheaper. Cosmetic outcome. There is no loss of volume, shape, no scars. Re-excision. 1 out of 5 patients undergo re-excision after lumpectomy due to unclear margins. It's a big number. Recovery time. 1 hour, 1.5 hours, and the patient can go cancer-free from the office. And use of operation rooms place an additional strain on the hospital. We give value for all. I'm not going to go about all those values that we give to the patient, physician, insurer, and the healthcare provider, but I can send you later on. We, IceCure, did the largest study ever been done in the world for breast cancer treatment with cryoablation with 194 patients with 19 medical centers throughout the US, and the results were amazing. 96.91 recurrence free. It's better than lumpectomy. With 100 satisfaction from the doctors and patients. And I'm glad to say that last week we had the last patients for follow-up after 5 years, and we just published it last week, and we are very proud. I'm not going to go over this. This is independent studies confirm the study from Italy and Spain. We also work in IR, in kidneys, lung, bone, liver, also for women health in the endometriosis. Endometriosis is a chronic, a very painful disease for women, and we give them a great solution for pain and for not having to have another surgery. This is the last slide. Just to show you that we are backed up by studies for all the indication, for endometriosis, for kidney cancer, for lung cancer. By the way, this is done by Dr. Nomori from Japan. For lung cancer, he proved that 77% up to 100% recurrence-free rate depend on the lesion size. That's it. Thank you so much.
Thank you for your presentation, and we've heard about this innovative approach, its comparison with the traditional approach of thermal ablation, the advantages and how it compares in terms of pain, inducing immunity, and others, and also a study that really gives the data to inform us about how effective it is in preventing recurrence. Thank you for that. So the next one is going to be Brian. If you can talk a little bit on innovative strategies.
Great. Thank you very much. I'll expand on this a little bit later in my talk. But one of the things that the gentleman from Partners in Health was talking about, he used the word systems 10 times. And one of the things that I've noticed over my 30 years international work and then time before that in the US is we tend to not think in systems. We tend to think in very vertical, isolated, I'm going to build a hospital, right? Or there's an insurance, there's a payer. And if you look at, an innovative strategy, and it may seem like common sense, but we tend not to do it. I live in Dubai in the UAE. We do not have a national healthcare system, right? We have 4 different regulators, right? So one of the most innovative things I think that most countries can do, especially when you're in a situation where you're creating, you're developing, is to really give a lot of thought to approaching everything as a system. And I'll expand on this a lot more later.
All right. Can we move on to the next one? Osgur? Thank you, Brian.
Sure.
You will expand later on.
Thank you very much again. My name is Özgür Temel. I am Elekta Sub-Saharan Africa Regional Manager and also medical physicist by profession. So today, actually, my entire career is on radiation oncology, and today my main focus will be what are the gaps and the needs when it comes to radiation oncology in Sub-Saharan Africa, and what will be the potential mitigation strategies to fill these gaps and address the needs in radiation oncology site. So I do have a short presentation to summarize these points. Right. So, as you know, the cancer is a global problem for us, and what we see is that world population is growing 1% every year, where the cancer incidence grows 2% every year. So in this regard, we can say cancer becomes a new global pandemic for us. And also, when we look at the access to radiotherapy systems, according to World Health Organization recommendation, every 1 million population should have 1 linear accelerator as minimum. So if you look at North America, every 1 million population is 12. Europe, it's 5. in Asia, where we have two most populated countries like India and China, 1 million population is 1 DINAC. So let's come to Africa. We have 0.3 linear accelerators for every 1 million population. So if we zoom in the Africa for this distribution, this is the information table from IAEA records. So the North Africa and the Southern Africa, they meet the minimum recommendation number. Every 1 million population has slightly more than 1 linear accelerator. But if we look at the Middle Africa, where we see is that it is 0.08 per population, per LINAC per million, and where we have almost 1.1 billion inhabitants where they live in. Obviously, radiotherapy access is a big gap in Middle Africa especially. So, of course, regardless of the machine, we definitely must have a competent clinical team. And when it comes to radiation therapy, we do require a multidisciplinary team, including radiation oncologists, medical physicists, and the therapist. So here what we see is that because of lack of the clinical oncologist number in sub-Saharan Africa, per oncologist may deal with more than 3,000 patients. So we also need to invest for our future for the competent human resource. So what will be the mitigation strategies for the lack of radiation oncology access? So one of them is that I strongly believe that the public insurance should be in place for the private institutions. So this is an example from Kenya. The NHIF provides a reimbursement for the private institutions per patient. And also in my country, I'm from Turkey. 15 years ago, we used a very limited amount of the linear accelerators. But since public reimbursement comes into place, today Turkey has more than 200 linear accelerators in country. So this public reimbursement encourage private hospitals and their investors to invest on radiotherapy, and then knowing that they will be paid by public insurance. And then, depending on their targeted patient group, they can request on top of it. But even they don't top of it, there is a guarantee from government that they will receive payment from for the patients that they treat under the public insurance. So it will be a good driver for the private investors. So partnerships is key. To increase the capacity. So here the public sector should be a driver and the regulatory body, and as well as a guarantor for the investments. And the private sector should bring in with an investment, both for the construction and equipping the centers, and as well as bringing the human resources when needed. And of course the vendors. Vendors definitely democratize the access to radiotherapy by offering the good pricing for sure, because the equipment that we are talking here requires heavy capex investments, and as well as bringing innovative financial solutions. And this is in Elekta what we are exactly doing when it comes to financial solutions. And also as a vendor, we provide comprehensive training and education, and as well as service maintenance for our equipment. So in Elekta, we are not supplying the equipment. We are providing a package solutions that address the needs. So by combination of the public sector, private sector, and the vendor, this is where we can get the magic and get the things done. It could be a mitigation strategy. And on top of that, we definitely need a competent team, as I said. So in this regard, teaching hospitals, universities should definitely open a training and education programs for medical physicists, radiation oncologists, and RTTs. So today I'm so gladly and heard that the Muhimbili University in Tanzania is opening a medical physics program. So it really helps to fill a gap when it comes to medical physicist needs. So definitely we should do that, and in Elekta we are more than happy to support such kind of residential programs, educational programs by all means. And of course, modern technologies help us a lot to fill this gap. So one of the technology in Elekta, the linear accelerator, what we call is Elekta Harmony. The beauty of the Elekta Harmony clinicians can able to treat the patients within 8 minutes. Just 8 minutes. 8 minutes patient in and out room time. So if you run your, so in 1 hour, you can do more or less 8 patients per hour. If you run your LINAC 12 hours, you can do almost 100 patients in single shift every day with single unit. So this is, and also it allows you to deliver the IMRT, 3D, conformal, even up to SPRT treatment techniques efficiently with a very limited time slot. So this is also a great workhorse system, and also mitigate the need, because most of the linear accelerators in the public hospitals, they are treating more than 100 patients a day. So for instance, the Elekta has a LINAC at Kenyatta National Hospital. The machine treats 110 patients every day, every single day, and the waiting queue is 6 months, which is not acceptable for cancer patients. So such kind of technologies really help to increase the patient throughput. And of course, another technology that should be considered is the gamma knife. With the gamma knife, it allows you to treat the stereotactic radiosurgery intracranial, and as well as the vascular malformations and the functional disorders with a non-invasive way. So if a patient goes into an operation brain surgery, the patient needs to be hospitalized for 3 to 4 weeks, and also there is another recovery period. And if the patient is the breadwinner person of the family, it will create a financial burden. And also it will create a financial toxicity even for the patients and the family. But with this non-invasive stereotactic treatment approach, same day, patients just discharge from the hospital and they go back to normal life next day. So, and also such kind of technologies helps a lot for the socio-economical burden. And of course, there is a lot of emphasis doing this software development and remote connectivity. Of course, in radiation therapy, there is a big implementation. Definitely, we should establish satellite centers. Most of the capitals in the sub-Saharan Africa, they do have a radiation oncology departments, but the other cities, surrounding cities, they don't have. And the patients need to travel long distance, and they need to stay in these cities for a quite long time. It creates another financial problems and the discomfort for the patients. What we can do is that we can establish a satellite centers and connect to main center as a command center, and this main center can do treatment plans and monitor the workflow remotely. So it reduced the need for the number of the medical physicists in the satellite center, which is where we are lacking. So this remote connectivity help to reduce the need for the medical physicists in the satellite center, and also these technologies should be in place. So this is, in summary, from my talk, how to mitigate the needs and the strategies for the radiation oncology. And I thank you again and again for giving us a chance. And what I believe is that in Africa, of course, okay, today we may have some challenges, but I strongly believe the Africa and its potential, and Africa and the future is bright. We definitely win this fight against cancer. So I'm so hopeful and so grateful to be partnering with you. Thank you again.
So thank you again, Oscar. We heard new terminologies and services that can be useful. The Elekta Harmony, Elekal Gamma Knife, and how this can be used to reduce the burden of socioeconomic status for the cancer patients with low downtime, efficiently treating more people at the same time. And we will ask so many questions later on.
Pleasure.
How cost effective it is, whether it's feasible in rural areas. Pleasure. And you did mention a very important aspect, creating satellite centers with remote connectivity and integrating these services. And Brian had already talked about systems. Creating the systems is a very important aspect. This brings us to a good transition to ask Dr. Jerry to the next question in the panel discussion. I'm sorry. So let's go to the next question, and maybe you can start by following up the presentations that were done ahead. and we will talk about collaborative research in Africa. You can say a few things on that.
Thank you. Research. As I said in my presentation, whatever we are doing, you cannot plan anything without data, without information. WHO published in 2018 that there were 13,157 research in North America. And this was 30 times the researches that were done in sub-Saharan Africa. So you can see how low the research output on our area is. So first we have to prioritize, because even the researchers that some of them we are collaborating and doing them, probably they don't answer the questions that we have. So the main thing probably I will start with, we have to identify our African research topics. We can start from incidence and mortality, because as we can see every year when they publish about the incidences in especially sub-Saharan Africa are rising every year, and the projection is we're going to have 1 million patients in 2030 and probably 2 million cancer patients in 2040. So we have to know exactly what are these risk factors that are around in our areas. We have to know our genetic profiling. We have to know molecular and biological effect that is around here, and then translate on what we can do in terms of from prevention, treatment, and also care. And also we need to have research on implementation science. This is a very new area that most of us, we are doing programs, but we are not assessing them. We are not doing the science on how to implement. Especially most of our countries have started the HPV vaccination. I think almost a lot of African in sub-Saharan, they've started doing it. But how are we getting value for money for it? But because we are expecting probably in 10 years, 15 years time to have this cervical cancer burden reducing. So how can we do these implementation science studies in order for us to compare the costs of treating this cervical cancer patient, comparing to the cost of investing in vaccination of these girls, and then translate and see the difference in terms of the economics of it, and then present it to whether the government or anyone who is basically involving in funding. So we have basically to have this implementation science. Of course, we have to have clinical trials, and most of these clinical trials is partnership and collaboration with other Western countries, US, UK, Europe. But we have to know the efficacy of these drugs. Because very few studies they've done to check on these chemotherapies that we are giving, targeted therapies that we are giving, even radiotherapy, to check are the dose same when I give this dose to a Chinese and an African, or a European and an African, in terms of, because as we said, we are different in terms of genetics, and even the environment. So clinical trials in terms of efficacy, toxicity, and the dose has to be in place in Africa, and this is mainly can be done through collaborations. And non-therapeutics now, non-clinical trial like psychological, survivorship, palliative care. We need a lot of this in our setting, more than even the clinical trials, because these are the patients that we are saving, almost like 70 to 80%. So we have to also talk about the financial burden that is there. We have to look at it in detail in a way that we can support these patients during their treatment. So non-therapeutic trials, they have also to be emphasized. Now, what can we do in terms of now we need infrastructures and resources? the lab space, the equipment, the reagents. As you know, most of this clinical trial that will require. So that is the area that we have to partner between institutions, all the partners and stakeholders from the pharmaceutical companies, from the tech companies, to come together and mobilize resources so that we can have answers or researches that are basically based for our consumption. The last one I wanted to talk about also is the workforce. I will be repeating about the workforce in research. Most of our clinicians or doctors, most of our doctors, I can say, they are clinical oriented. They are not research oriented. So it's very difficult to find a surgeon involved in research in Africa. But it's part and parcel of activity when you are in US. You are a surgeon, you are publishing almost every day. Whatever you are doing there is information. You have to give it out to. So we as Africans, especially clinicians, we have to change that mindset. How are we going to change? It's basically also through training and exposure. So through these collaborations with inside and outside Africa, within ourselves, we have to at least pass this information, pass this knowledge to each other so that we can have workforce that is not only clinical oriented, but also research oriented. So that's all I wanted to talk about collaborative research in Africa.
Thank you, Dr. Jerry. I think this will take us to the next speaker, Dr. Eric. Dr. Jerry has highlighted that the region lags behind when it comes to research, and we need to pick up the pace there. And priority for African research in cancer should be decided. That would guide us to see what kind of incidence rates we have with the different kinds and risk factors. And then implementation science should be promoted, as well as workforce development, with a focus on making clinicians related to research and increase research capacity through training and networking across African countries. And I think this is a good segue to Dr. Eric's presentation, who is the epidemiologist here at IRCD.
Yeah. All right, thank you very much. I thank my colleagues for the good presentations, and mine will not be much different. I will equal to what my colleagues, especially Jerry and Jack, presented. And first of all, as we've seen that like there was a decrease maybe in cancer mortality in high-income countries, and we are now seeing an increase in cancer mortality in like low and middle-income countries. So this can be due to different facts, and that will not repeat here because of the time. But this increase is also give some task to ask about what can be done. So, sorry. So as now, the first thing, in epidemiology, the first thing to do with the detection, and as now detection rates and therapy success increase in high income countries, it's now predicted that like in the next decades, more than 75% of cancer-related death will occur in low and middle income countries. This gives another reason why to invest much in Africa, and why Africa needs now to take the lead on the cancer. So when it comes to research, we know that like the pyramid of evidence starts from maybe from an idea to cross-sectional studies, and maybe the high ranked will be the clinical trial. But when you look at different studies that are conducted in our continents, we are seeing few clinical trials. We are seeing few digital solutions. Maybe if you can see from the presentation done by Jacques, we have seen that there are many studies conducted in Europe, in America, in Asia, but like the only thing that we had in Africa was the launch of IRCAD Africa in the last 6 months in Rwanda. The same with my colleagues, like all those colleagues, IceQ, there's nothing in Africa except in South Africa. So still, Africa needs more research. We need, as now the epidemic is increasing, we are in need of more evidence, and we need more studies. We know that the future is bright, but when you look at what has been done so far in Africa, on different countries, the only thing that is done is some, like, understanding the epidemic, the trend. So, like, these are data from Rwanda showing, like, the increase in the diagnosis. You may say that, like, from this slide, that maybe you are getting more people who are, like, more incident cases on cancer. But that's not true. The truth is that, like, from the beginning, like, when we started our cancer registry 15 years ago, we had low capacity to detect all the patients with cancer. And this can be demonstrated through this map. Back in 2009, when this have started, we could identify people from only few regions of the country. And as we've been maybe scaling up the treatments, getting more sites, more hospitals, more workforce, clinicians, we can see that as of now, like, we can detect all the patients across the country. So this means at least the country has done some efforts to detect and to diagnose patients with cancer, and we are able to detect, like, any cancer in countrywide. So, but as I said, we are still at the phase of understanding our epidemiology. And the same here, we are still the first to know which cancer do we have the most, and which age group is suffering more and by gender. So now, as you understand from the presentation that we had from Jacques in the morning, it was to, like, high technology and how high technology is used to treat cancer, and the same like we had from different companies here. So now we can understand, like, the journey is still long to know to use the technology and to have more advanced research. So we have some challenges. Some were said by my colleagues. First of all, is about lacking of ownership on research. So we know that, like, sometimes our research agenda is driven by external funders, depending on how much they have and where they need to invest. We are still having a low capacity in research and development, like including training facilities, and how we can also retain our talents. Sometimes our talents go back to Europe or to America, and we cannot retain them on our continent. Infrastructure is still a challenge, and my colleagues Jerry talked about this. And we are not able to conduct, like, some experimental studies, even some also to take some images that can help into diagnosis. So sometimes also our efforts are very fragmented. Here we can say, even in East Africa, we are not able to know maybe what's happening in Tanzania and how can we collaborate. So this is a slide that show about research collaboration, and you've seen that, like, maybe this is not only cancer, but it's research in general. You've seen that most of African scientists, they are collaborating more with European and Americans than we are collaborating between ourselves. So that's a challenge, and this maybe it's urge more collaboration and advocacy, how Africans can collaborate between themselves, share what they have, and make a big team. So as I said, the future is bright, though there are challenges, but there are also some opportunities that we can explore in Africa. As you said, when Jacques presented, he was saying that there's some cancer that maybe they're not able to test, some surgery that they can do in America or in Europe, but they're doing it in China because they have more cases. I think also in Africa, we still have cases are rising, and that's also like an opportunity to increase research, which will help into reducing the cases and will also help in treatments. So there's a political will, and we're seeing that some universities and pharmaceutical and biotechnology institutes coming in and now increasing, and that's also an opportunity also to increase research. Now, we know that we are targeting, like when you look at the growth of biotechnology and pharmaceutical markets, it increased, like there's a projection that it will increase, like the fund coming from those institutions, it will increase almost double by in the next 8 years. Also, we know, like maybe giving some example, that like now, not because I'm Rwandese, but we're not happy to see that now Rwanda is hosting the BioNTech and we're having also Alma having their regional office in Rwanda, and IVI, which have started, and now we have CDC Africa, which is there to support all our continent initiatives, so that research can be improved and the public health as well. So as a conclusion, we can also say that we have many challenges, but we are still believing that the future will be bright. We should increase the collaboration and also to address some gaps, including infrastructure, workforce development, access to medication diagnosis, and preventing measures. And research should follow all of those and also be part of those initiatives. Thank you, and thank you for.
Thank you, Dr. Eric. You brought up a very good point in the fact that there is increased cancer being reported, incidents being reported in Africa, and this could be due to increased detection rate and probably not necessarily just increase in incidents, but we may be detecting more because we are doing more to find and treat these cases. So the other point is that he was able to demonstrate that there is very little collaboration among African countries, but most of the collaboration are with the Europe or America investigators. There's nothing wrong with that, but the point is if we had a collaboration among ourselves, it creates a more conducive environment for the research ability to be, the capacity to be improved locally, and also the ease of connection, which would make things faster, and ownership of data and ownership of the research itself may be easier because there is not too much leverage when it comes to ownership of the data and ownership of the research itself when we depend on external funders. That calls for local investment, and I think increasing local investment without a doubt is a very important strategy that one needs to think about when improving cancer care. So let's go back to the last section of our panel discussion, and this one is looking at the international collaborations. So I would like to start with Brian or Dr. Jerry to start commenting on the international collaboration in cancer, in research activities and partnership to advance cancer research on a global scale. let's say something about the global scale. I think we have been focusing more on the regional aspect, but let's touch upon the global scales briefly.
Thank you. I will still insist on research infrastructure. As I said before, most of these infrastructures, especially when you want to answer questions, especially in clinical trial, need partnership not only in sub-Saharan Africa, but also with the rest of the world. And knowing different patterns of this disease as well is also very important to collaborate in different regions. So let's say colorectal cancer. I'm doing a PhD study in colorectal cancer. The burden is rising now in Africa, especially in sub-Saharan Africa. And the pattern now is on very young generation, around 20, 30, sometimes even to 40. The picture is totally different the past 10 years that we are only getting the old ones in colorectal cancer. So knowing the genetic pattern, comparing it in sub-Saharan Africa, comparing it with the Europe and Asia, and see how we can know exactly how this the disease presents is very important. So collaboration is not that only important for the infrastructures and the resources, but also this data that you can get because of different pattern, especially in terms of genetics between the other regions. So it's must to have these researches that are beyond only in sub-Saharan Africa. Even in the drug development as well. As I said previously, the toxicity, the efficacy, and all that has to be not only in one region, at least to have a global to answer the question globally, so that you know the same drug can act differently in different settings. So if you have a trial, if you have collaboration that caters for all these regions, especially different populations, Asians, Africans, Europeans, and then you will have answer that probably it will help not only in treating our patient, but even in the development of the drugs. All these new targeted therapies that are developed, they are very, very important for us to use for our patients. Workforce also, as I said, in sub-Saharan Africa, the workforce is inclined to clinical rather than research. So partnering globally, knowing what is the other side doing, like what Prof was telling up here in terms of the AI, we need that global collaboration so that we can have a global knowledge or global technology, but convert it and treat local patients. That is what is important. You can have a global information, global knowledge and all that, but if it doesn't translate directly to our patients, then that will be just a kind of just a luxury in our setting. So in these collaborations as well, these researches has to translate directly to what to our patients in terms of the outcomes. Yeah, those are the things that I can point out.
Thank you, Brian.
Thank you. I started my international journey 30 years ago working with the Johns Hopkins School of Public Health. And over the past decades, I've worked in various different, on both sides of the table regarding partnerships and collaborations. I've been on the provider side, whether it's Johns Hopkins or Cedars-Sinai out of LA, but then I've also been on the recipient side. I worked with Dusa Medical Services in Thailand for many years. So we were partnering with European and American organizations. The one main comment that I really need to make, and is really important, is on one hand, and we've heard this several times, we need to hurry up, right? We're behind, we need to hurry up. And I get it, you need to hurry up. Everything should have been done yesterday. At the same time, regarding these international collaborations, you need to slow down. because I've seen more often than not, people are in such a hurry to get into one of these international collaborations and to sign the agreement and to do the press release, and then 18 months later, it's blowing up because it's failing to deliver on expectations. So yes, hurry up, get on it, and plan them, but then before just jumping into it's just like getting married, right? Do some dating first, really do some due diligence, really plan, understand what you want and need out of that relationship, because it's not just, I know, for my professional career, it may look great, me signing a deal with Johns Hopkins and going to Baltimore and all that, but it may do nothing for your patients, right? So really understanding what you as an individual, what your organization, what your country, and most importantly, what the patients need out of that relationship, and write it out crystal clear. Go to ChatGPT, get some help with that, you know what I mean? But make sure that when you're looking for those international partners, you are crystal clear in what you need and how you're going to quantify that it's delivered, right? Because that's so important. Yeah, that's all I got.
Okay. I think these are very important messages. Yes, we need to collaborate among ourselves, but also globally. It's not only for their infrastructure or funding that we collaborate with others, but to have a deeper understanding of the disease, the risk factors, and the responses to drug treatment and therapeutics. It becomes relevant to see what the research provides in terms of data that will inform our clinical practices and our measures in planning and policy information. And I think the last one by Brian, it's good to have international collaboration or even regional collaborations, but we have to contextualize what we are getting into. We have to understand what the benefit is for our patients, for our scientific growth, for our patients. We have to clearly know what we are getting into in terms of what advantage that will come out of this collaboration, how far it will go, whether it's ethical and it's sustainable, and the result is going to be informing our policies and practices. So having heard from our speakers, the floor now is open for questions. Yes.
Thank you so much, our speakers. I have 2 questions related to research. I would like to understand if there are opportunities to do the type of research that will inform the government on the benefits of expanding the diagnosis. I'm looking at the statistics. They are quite worrying that in the next few decades, the cases will increase by 75%. Looking at the health sector budget in East Africa, the curative budget is quite high. And for me, I feel like it is necessary to invest on preventive. So are there researches that will help to inform the governments on the benefits of expanding the screening services? I come from Tanzania,